We on? All right. Good afternoon, ladies and gentlemen who have joined us on this Dr. Fundi channel. My name is Dr. Fundi Lenyati. I'm the host of this channel. Today, we have a special guest, Dr. Sebolelo Seape. She is a specialist psychiatrist who's practicing in Soweto at Sepotemba Private Hospital and also at Akiso in Parktown. She is here today because she's one of the leaders, in the psychiatry, field. She is the president-elect of the South African Society of Psychiatrists. She's also the chairperson of the Psychiatrist Management Group. So she's basically, somebody who is definitely the right person to talk to look at issues of mental health in the South African, context. As the president-elect of the South African Society of Psychiatrists, I'm sure they are busy looking at many things that have to do with the state of mental health care in South Africa. So it's basically very, very important that we don't just look at the micro issues, but we also look at the macro issues to say, how big is the problem of mental health in the South African context? That is the burden of mental health disorders to the healthcare system in South Africa. Also say, how should it be in an ideal world? So that we can then say, what is it that needs to be done to move us from where we are to where we need to be? So I hope our discussion with Dr. Sebo, will be able to help us just to have a better understanding of how challenged our country is when it comes to issues of mental health care, services, and other countries that have got better resources. What have they put in place that maybe we could learn from so that we can take better care of our patients here in South Africa? Dr. Sebo, welcome to the Dr. Fundi channel.
Thank you very much, Dr. Nyati. Thanks for having me.
Thank you. Thank you. I think my opening remarks will be that this year is the 28th year where we are celebrating the World Mental Health Day. And the theme for this year is mental health for all. Greater investment, greater access. Now, just looking at that, theme for the year, Doc, how relevant is it to our South African situation?
Yeah, thank you. It is so very relevant. They're almost talking to us specifically because South Africa is not at a position where we can say that everybody has mental health care services at their disposal or they have the access. And I think we all know that in terms of the investment, it has not been greatest. As I'm sure you're well aware, World Health Organization recommends that governments should spend about 10% of their budget on mental health. And I think we are somewhere between 2 and 5%, which already says that we are underspending on that particular area. And I dare say that from province to province, could very well be less than the 2 to 5%. Going further to that, funding, both by law and what government does, is that you'll find that mental health is funded at tertiary level, not at primary level. So by tertiary level, I mean at the level of specialists. Yes. As opposed to primary care, where most people go to and have best access to. Yes. Because primary care should be free for all those who cannot afford it. In fact, for the general population, should be free. But you'll find very few community clinics that will have mental health services. And when they do have them, it is once a week. Well, it comes to once a month or even once every 3 months, depending on the numbers they have. And they're not funded. So even in the private sector, you'll find that the PMB laws themselves only fund tertiary care, not primary care. So once you're out of hospital, you have no care, or if you are in hospital, then you can access care. But we know that a very small percentage of people do have private funding anyway.
Yes,
so already there.
Only 17% of South Africans are actually covered by medical aid. So you're very right. Yeah.
Yeah, and then they're only covered in hospital. Once they are home, where we want them to be. We want people to be treated at home and still continue working and being functional, but then they have no services. So then they drop in their care if they had already accessed it. And I mean, sadly, you'll find that a lot of even those private funders don't have any out of hospital care for one of the biggest or most aggressive illnesses, which is schizophrenia. Yes, a whole lot of medical aids will pay for out of hospital funding for schizophrenia, which is really, but they're able not to pay if they don't want to, because the PMB law doesn't cover that. So it is their generosity. I know it's not easy to say generosity when talking about medical aids, but it's their choice, really, which is a pity.
Yes. Actually, I was also going to highlight the fact that, what you've just said, Doc, that, as much as people are covered by medical aids, I'm talking about that 17%, but those benefits tend to be quite thin. Some hospitalization, even there, the number of days are limited, up to 21 days. After that, you're out, and you have another need for hospitalization, you may struggle. And the day-to-day benefits you're talking about as well, they tend to be quite limited, and so, so we definitely have a challenge, when it comes to the covering, especially of the majority. Now, having then said that we have that challenge, Doc, in terms of not enough investments into the mental health space, the services, and also problems with access to services as a result of the fact that funding is more at a tertiary level. If we just go back and look at the load, the need out there for mental health services, do you have an idea of, how big is the challenge or the need out there for people who are actually living with mental illness? Or maybe let me put it differently. We're going to look at that need from a general population point of view, from a workplace point of view, and also even the medical profession. I'll share one or two things, just to guide that discussion, if you don't mind. Now, there's an article that appeared on the South African Medical Journal 2 years ago, which was a study that was done in the Western Cape by Dr. Jacob and Kutsier. They were looking at the 12 months prevalence of common mental disorders among South African adults. And what they found was that about 16.5% of adult South Africans were actually suffering from mental illness. And that obviously did not include the children, but it also did not include people with psychotic, challenges. Now, I just wanted you to just, just from that state, your opinion or your view about that prevalence, and that was basically something that was published only 2 years ago.
Yeah, no, I'm in agreement with that it is a good ballpark figure. And I think even World Health Organization recognizes that between 15 and 25% of people, it translates to somewhere between 450 and 500 million people in the world are afflicted at any one time. And I think the lifetime prevalence increases to all the way to 39-40%. So the load is huge.
Yes.
And as you said, that study looked at adults and excluded children.
Yes.
which are part of the society, and the healthcare worker has to look after them too. And
Yes.
a reasonable amount of people, or number of people, have got psychotic illnesses.
Yes, and that was
And
excluded.
if we leave them out, then we will have underplanned completely.
Yes, 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 yes. Now, so that was the situation in terms of the general population, or that is the situation that, like you said, WHO says anything from 15% to 25%. So this study talked about 16.5. Another one that was done it was Global Burden of Disease in 2015. It also gave the range of 15 to 18. So basically, we are around the same ballpark figure. Now, Doc, with such a load in the general population, do we have enough capacity as a country? And here I'm talking about the professionals that are supposed to assist. And also on the other side, I'm looking at facilities.
Yeah, sadly, again, the answer is no, we don't. Earlier this week, I'm sure you heard, we were talking about the average number of psychiatrists in the country, and
Yes.
we are working at about 1,000 plus minus. But that 1,000 is also very generous, because it also includes people who are retired already, people working in industry, people who are abroad, because this is the number that was taken from the registered psychiatrists.
Yes.
So even people who are abroad are still registered, so they add to that number, but obviously they are not there to serve. So the number
sorry, Doc. So we're saying 1,000 for the whole country.
For the whole country.
Plus minus. Yeah.
Plus minus.
Yeah.
But that includes these groups that are not there.
Yes.
That are not serving people, So you can already imagine that this is a serious situation. In terms of ratios, World Health say an acceptable ratio is 1.5 to 100,000. In South Africa, we are, in terms of psychiatrists, we're at about 0.5 per 100,000. Of course, we will not even compare to First World, where they range anything from 12 to 20 per 100,000. So
Yes.
we're not in that league altogether. So yeah, it stands to reason that the numbers just don't add up. So the burden is huge.
This is for a population of plus minus, 60 million people.
Yeah.
Wow. That's quite problematic. To have just 1,000 for 60 million people, I think it's a serious need, or there's a serious need for deep reflection on that. And in terms of facilities, let's look at the public health sector, because like I said earlier, the majority of the people in South Africa are dependent on the public health sector, which services somewhere around 83% of the population.
Excuse me. I was just sorry. I was just saying, the numbers that we've just quoted, I've moved one step backwards, are low and will remain low. Because if we think of, I'll talk about just psychiatry, because that's what I know best.
Yes.
First of all, we know that no medical school has been built in forever and ever in South Africa. So the numbers of doctors, never mind specialists, will not increase in any great hurry. The last medical school that was opened was, I think, University of Transkei,
yes,
which was in 1985.
Yes.
And the population then was 30 million.
Yes.
Now the population is now 60 million, and we still have the same number of medical schools. And we know that in terms of specialists in psychiatry, definitely there is a quota per university. So there is a limit to the number that can be trained. And we are well aware that that quota will not cover the numbers we have. And I think the government has been sending students to Cuba for medical training. I suppose that would be the counter argument for not building more medical schools. But yes. there isn't, for me, it wasn't the wisest choice. I'm not saying it's wrong, but it wasn't the wisest choice, because they're not planting their own timber,
Yes.
So you will continue to send to wherever, whereas in the time that they've been sent to Cuba, I think a medical school or 2 or 3 or 7 could have been built by now.
Yes.
So there is a problem there. The facilities themselves, have not increased dramatically. I don't have the exact stats, but I
Yes.
don't think there is a brand new hospital that has been built that has a good psych unit. I'm sure there are regional hospitals that have been built and clinics, but I'm sure we all know that the clinics are terribly understaffed and under-serviced. I mean,
Yes.
when I was working in the clinics as a registrar many years ago, the bigger clinics were just disastrous. I don't quite know how we would, because you'd find like a big clinic like Zola Clinic. When I arrived there at 8 o'clock, there's already 84 patients. I mean, there is no way you can service 84 patients in a day. And it was an unfortunate service. I would like to hope it has improved tremendously, but I'm not convinced.
Yes. So, so when we're looking on the professional side, and here we're talking psychiatrists, there is fewer numbers that are being produced compared to the need, or there's few numbers that are produced compared to the need. Also on the facilities side, there hasn't really been much upscaling in terms of facilities. I do remember though, I think Kimberley, they opened some facility last year, and obviously one doesn't know. I mean, Kimberley, it's a province with the smallest population in the country. So I'm not sure how much dent that will, facility will do in terms of increasing capacity, in the rest of the country. But what about the other professions, Doc? We've talked about psychiatrists. Do you have any idea, maybe, or psychologists, social workers who are also part of the professions? Not exact numbers, but generally, can one say there's a similar challenge of capacity at university level to actually produce those?
I will not speak with any degree of actual fact and knowledge.
Yes.
But I mean, just in terms of nursing, I think in the 90s and early 2000s, I'm not quite sure, I can't remember, a lot of nursing colleges were closed. Many hospitals used to have nursing colleges.
Yes.
And then they closed. And a lot of training now is left up to private institutions, which I think is not good enough. And there has been a steady leak of nurses to UAE and UK and all those places, which is unfortunate. The psychologists and the other members of the health professional health providers in mental health, I don't know about their training, but what I do know is that even now in the community clinics, you don't always find a psychologist, you don't find an OT, you don't find a social worker. And the social workers that you'll find that they're not just for mental health. If there's a social worker, they are doing everything. And so there is no way they can spread themselves that thin. And it's still the same really in most clinics, that you'll find that they have to go somewhere else, or the other members, a social worker OT comes once a week, and can only do so much in one day. It's still very underserviced. And of course, if you go further from the urban areas to the rural areas, then services get even further and thinner and thinner. As you mentioned, Kimberley, I mean, when in that 1,000 psychiatrists in South Africa, and a study that was done, I think 2 years ago, it was a proposal that was already looked at, that was done by the college in SASOP. There were only 4 psychiatrists in Northern Cape.
In the whole of Northern Cape, yes. Because I do some work in the Northern Cape where we have to refer employees or government employees that need second opinion medicals, for ill health retirement and things like that. And it's always a struggle to get an appointment. Usually you have to wait like 3 months, maybe to get an appointment, which is a symptom of the fact that there's just, the numbers are just, too low. Yes. Yeah. Now, because I said we look at the general population, in the workplace, now that's the space that I'm working in, Doc. So maybe I'll share 1 or 2 things there just to guide the discussion there as well. Now, in the workplace, there was a study that was done by Professor, I think, Krieg Lund from USB. on looking at the prevalence of mental health in the South African workplaces. And they found that 1 in 4 people who are working in the South African workplaces has a mental illness, which means that's like 25%. That was pre-COVID. All of this was pre-COVID. And they further said only about 25% of those people actually seek help, meaning many of them have an illness but have not sought help, which then creates a situation whereby people are at the workplace, they're not at the optimal level, cognitively and otherwise, because of issues around stigma and other things. So I just wanted your comment around the 1 in 4 people who are working in South Africa being people who are living with a mental illness.
Yeah, no, I agree with that stats. In fact, even for the general population, I mean, we have been using 1 in 4 as a reasonable number, not just for workers, but for everybody. And in fact, I think the past year or two, we are now even 1 in 3, which is getting hectic. And yes, a large percent, I mean, if your quarter of your workforce is not well, it is a huge loss. And there are many reasons why people 1 in 4 are diagnosed and less are even seeking help. Because we remember that in the workplace, there are lots of stresses. The workplace is a stressful place. I mean, it doesn't matter what job you do, it's a stressful place. And the job either gives you a mental illness or it worsens what you already have. That is sort of what happens. But it depends on many factors that have to do with the workplace itself. And why people don't seek help or are not getting help, we know that mental health literacy is not yet a thing in South Africa. Lots and lots of people don't know about the mental health conditions. They don't know if they have a mental health. They will know that I'm not feeling well, I don't feel strong enough, I feel unwell, I'm sad, I'm crying, but they don't know that it's an illness. So that already precludes people from going. And then other people might know that they do have a condition, but there is sometimes a belief that it will go away. It brought itself, so it will take itself away, that type of thinking, which is a little bit inadequate. And then some people who might have sought help might be dissatisfied with the help they got, whether it is the attitudes of the health professional, whether it is, getting there, whether it is the medication or whatever. They might just be dissatisfied. And there's an attitude as well that mental health medications, especially, or all the help you get there, the therapies and the medication, don't work. In my view, that why people generally think it doesn't work would be because from the get-go, the mental health professional did not discuss sufficiently with the patient about what mental health is all about and what the symptoms are and what the treatment entails. Because I think people are used to thinking that if you're sick with anything, you'll be in bed and there'll be a drip and a tube for this and a tube for that. So if you're standing and walking, then you're not sick. Number one. Number two, people also think that whatever illness you have, a pneumonia, in 24, 48 hours, it's done, it's healed, you go home. And I think that's sort of the position that a lot of people are at, that things treat reasonably quickly and go away. And we do know that a lot of mental health conditions don't treat quickly. And you have to be in treatment for quite extended periods of time. So if this discussion did not happen from the get-go, so somebody takes medication for 5 days and they still feel the same, so the conclusion is that it doesn't work. So people don't seek help for those. And then, especially in the workplace, when people seek help, there are problems sometimes, depending on the employer, depending on the employer's level of literacy. I'm talking about mental health literacy and understanding. They might not get time off, or if they get time off, then it also is money off, so to speak. So they're not going to be compensated for those hours that they are away. So it becomes a problem when money is tight. Even when money is not tight, it becomes a problem when you're not getting paid. Or sometimes you find that people have got issues of disclosing, from the beginning, because they're always worried about the stigma that will come. They're worried what colleagues will say, what their bosses will say. And there's always this unfortunate issues of people making sort of light jokes of mental health conditions. You know, it will be called a joke. If you had to take it up, it will be called a joke. But actually, to the patient, to the sufferer, it's not a joke.
Yes.
So it's a problem. People don't disclose, and therefore, because you don't disclose, you can't be given time off.
Yes.
Or sometimes it's just people don't continue services because it's too expensive. Whether it's about paying for the service, whether it's about losing money at work, as we've already said, or it is getting your transport there. A lot of people don't have their own transport, and they have to rely on public transport, and it costs money. So there's a lot of reasons why a lot of people are not being treated in the workplace, and indeed anywhere else.
And in fact, just to support what you said, Doc, you know, I saw something, I think there was some survey that was done by SADC in 2017. You know, and they actually said a number of people who had disclosed that they had a mental illness to management, they had a negative response from management as a result of the disclosure. So, which actually discourages people from actually coming forward, you know, to say, I have got this challenge, I need assistance, I need to be reasonably accommodated, and things like that. So that's the situation in the workplace. We've got, obviously, I'm sure other industries are more affected than the other. You know, in the work that we do, we tend to see that, let's say in the government space, the education sector, the justice and security sector tend to show more of you know, people with those kind of challenges compared to others. You know, so I'm just saying, whilst the 25% is the working, you know, prevalence, some sectors of the workplaces may even be more than that, you know. But anyway, Doc, now let's go back now and zoom into our profession as the medics. You know, there's a lot of people or articles that have been coming out, you know, about the prevalence of mental illness within the medical profession. I mean, one of those, there's a journal or a magazine rather called the Medical Brief. It had a headline in June 2018 that says South Africa's silence over the high stress levels and burnout amongst the medical professionals. And basically they were saying there's a big problem, but we are not dealing with the problem. Now, in your experience, Doc, you know, and I'm not looking for exact numbers, do you think, you know, this profession, the medical profession, inherently it's a stressful kind of job that would make then the professionals who work within this space to be at high risk of presenting with mental illness?
Yeah, I'd agree with that wholly. I've said that all jobs are stressful, but I don't want to stratify which one is more stressful than which one. But I mean, we know that the medical profession is very stressful. Right from the beginning at medical school, you know, students are working much, much harder. And once they get into the clinical years, they are even more burdened. I mean, those are the years that they start going to the hospital and seeing patients. Yes. It's even more burdensome because you are still a full-time student and you're almost like a part-time worker as well. So already, just in terms of volume, you are overburdened. And the numbers, the number of hours you have to be fully functional is too high. And it really calls for a lot to try and be functional in all your hours. I mean, there are hours, especially, you know, I don't know if people know that there's call when people are working the whole day, the whole night, and tomorrow as well, working up to 36, 40 hours. It's a hell of a long shift and it's tiring. And tomorrow you have to come back like nothing has happened. It's difficult. So then they get out of medical school and training, or whether it's registrars or as, you know, junior degree. And I think there is something in it that says doctors are just somehow slightly different from people. Therefore, they can just work and work and work. And they have no feelings. So they face all this tragedy of sick people, dying people, and they're supposed to just carry on. And then, unfortunately, I think a lot of doctors sort of take that in as well, that they're not quite normal people, so they can take all this tragedy and death and sickness and all that. And that is just stressful, you know? I mean, we know that you just hear of somebody dying that you don't even know. And it doesn't sit so well with you. But now, if you are in the hospital or setting or whatever medical facility, and somebody dies, and and they die at any age, 2-year-olds or even babies, and loved grandmothers, and men and women supporting their families, it can be easy. That is the one side of it. Then the other side of it is just the numbers. The numbers, we've talked about numbers and personnel, are just too much. You work and then you work and then you work. Number one. Number two, because you're working with such high numbers, many a time you get a bit uncomfortable yourself. That did I do the best for that person? And when you go home, you think about it. Did I check this? Did I check that? Did I do this? A lot of worry, and sometimes some guilt, or somebody does badly and you think, hey, did I do the right thing? Did I put everything I should have? Did I check that blood result? So even when you're out of work, there's a lot of thinking, a lot of worrying. And then at least when I was at medical school, there was nowhere where they said, this is how you look after yourself. We never had anything like that. Maybe I'm hoping that it's better now, that you are advised that you must take better care of yourself. Because if you don't take care of yourself, you will be sick. Then you won't serve the very patients you say you are serving.
Yes.
So doctors don't do that. So they do the long hours, they do the emotional trauma, and then they don't look after themselves. You find that many, many times people are just tired and dragging themselves, but they still carry on, And there should really also be something that almost forces the doctor, I think, to say, how many hours have you worked? Therefore, you must stop, or you must do this, or something that checks, fine, outside of your working with patients, what else are you doing? Is your life full? I mean, are you, I don't know, breeding dogs, running a junior soccer team, something that just gives you more meaning to life, and do you do other things that restore you, whether depending on your liking and how you feel about things, with things like meditation and things like yoga, all those stuff. I mean, there's a lot of things that doctors should be investing in for themselves so that they are in the best kilter, but they don't, unfortunately, many times. So they're bent out, they're tired, they're depressed, they're very anxious. I mean, just having that gravity of knowing that this person's life is dependent on me. At times, it's a huge burden. Too much responsibility.
Yes, and I mean what we've just said now, Doc, about the levels of burnout, across the profession, and it's not a South African situation only. In the US, the Medscape, they did a study, the National Physician Burnout and Depression Report, and they found that almost half of all people who responded there, were actually complaining of burnout. They were coming to work, but they were emotionally, physically exhausted. They didn't have such a positive, attachment to their work, and in some of them, the quality of the work was starting to go down, which then brings me to another situation, Doc. Yesterday, I was looking through, one of my guests yesterday is a doc who's been living with bipolar mood disorder. And she talked about the issue of impairment, by the council. She was reported as a possibly impaired doctor. And as I was looking through that, what surprised me is that in the top 10 of the different professions within the HPCSA, 4 out of 5 in the top 5 were actually medical doctors. Guys who are GPs had the highest at about 60%, followed by interns, medical interns, followed by student interns, and then also medical specialists. And then to complete the 5 was the dental professionals. And the overwhelming majority of these people, they presented with various mental, health challenges. And so as we are talking about these levels of burnout, within the profession, I'm also now trying to connect the fact that quite a number of our colleagues, at times, they get so affected by these conditions to an extent that some people may then, report them that they are not fit to work, which then will bring me to what needs to be done. But we'll get to that one later, Doc. But I just wanted your comment around the high levels of burnout and the possibility that it could make the doctors to be less efficient, in terms of doing what they were trained to do.
Yeah, no, the levels of burnout, of fatigue, of depression, and mostly anxiety are so high, and it's, I suppose, we always think that our patient need us, but we forget that we should need ourselves before more than the patient needs us, so that we can actually serve the patient. A lot of people, and I think even an unofficial study, if you ask 5 of your colleagues at any one time, how you doing? I'm so tired. That is sort of a standard answer. But they're so tired, but they're there at work, doing what has to be done.
Yes. And now,
I've never had a medical professional say, I'm full of energy, I'm all ready to go, and I could do this. No, it's always, I'm so tired, And you get home, and the thing is, we get tired, then we get anxious, then we get depressed, and then we can't function properly. And now we are more tired and more frustrated because we cannot functioning at optimum. It becomes a horrible cycle that just keeps going on and on.
Yes. Now, then COVID came, which is a global problem. But here in South Africa, how from your vantage point, Doc, in the area of mental health, how has it impacted the country, and maybe even the profession?
Yeah, COVID pandemic has worsened a bad situation. The COVID pandemic, I think, will go. I don't know when, but it will go. And I think already we know that the numbers are going down, although we have heard that there's going to be a second wave. Yes. But they are definitely going down. But the mental health consequences will be with us for a much, much longer time. Yes. A lot more medical staff and general people. You see, the thing is, we have to remember, it's not just medical staff, but everybody is much more anxious than they've been. Is a little bit paranoid. And the lockdown rules that were necessary and have done a very good thing have unfortunately worsened potential mental health problems, or even initiated new ones, because the level of anxiety has gone high. And people who are already living alone or isolated now are being forced to be isolated. People you'd go out, even if they're living alone, or go out and meet friends at coffee shops and things, or visit each other in their own homes. And they're not allowed to. And I mean, there was a period of 6 or 8 weeks where people were completely on their own. Yes. That makes things terrible. And then, of course, there is the bug itself, the COVID bug, which is out there. And so we are all living in fear. We're all worried that we're going to get infected. And a lot of us working in hospitals think, oh my goodness, is there a possibility that I'll infect my family? And nobody wants to think of infecting their family, and then a family member does badly when they didn't do badly. It gives you the guilt that you won't be able to live with. And then, of course, the medical staff that's working with the patients with COVID are so anxious. They're so worried that they'll take this thing home. And for patients who die, it is so uncomfortable for medical staff, because they are the only people now who are not just doing their nursing job or doctoring job, but they are actually looking after this person's emotions. They are the only person that this patient meets. And these patients die only in the company of nurses. They never see their families again. And it's uncomfortable for families at home. It's uncomfortable for the patients in the hospital. It is terrible. And of course, we cannot leave out the economic burden that has brought on. That in itself has increased the anxiety of everybody. People have lost jobs or are losing jobs. Business closed down. The economic burden is just so big. And that in itself is so stressful that, again, our mental health problems are increasing. Yes. So yeah, the COVID has increased and worsened a bad situation, and it will be for a long time.
Yes. And in April, just to get a sense of how people were impacted by COVID-19 in South Africa. And they found that 65% of their respondents felt very stressed during the lockdown, you know. The main challenges that they presented with were issues around anxiety and panic, financial problems, family relations, feelings of suicide, substance abuse, and for those who had pre-existing mental health problems, depression was the leading problem, followed by anxiety and bipolar mood disorder. So it's just showing that it impacted, negatively. And it's not only people who already had a diagnosis, but there were a lot of new people that actually got to be diagnosed for the first time with mental illnesses as a result, of this COVID-19. Now, it's often said that COVID-19 pandemic exposed weaknesses that were there in the system. So are you also in agreement, Doc, that obviously we had a bad situation before COVID, but when it comes to mental health services, we are likely to have more challenges than even before, going forward?
Yeah, look, I started by saying that the pandemic, this particular pandemic, would pass, but the mental health consequences will last for much, much longer.
Yes.
Yeah, and the exposure of weaknesses was great. If we had had a slightly more functional, active or alive mental health service in the community, with good screening and good referral systems and a very strengthened primary care system, a lot more people could have been, first of all, could have been suspected.
Yes.
What we'd call a risk population. We should have, from the get-go, have factored in the fact that people are now at risk. So the mental health systems must be enriched, must be strengthened. The lockdown, committee or whatever, looked at all the physical things, the social isolation, masks, blah, 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 all those things that we know. But there wasn't specific attention paid to mental health.
Yes.
So there was no, if you're feeling these symptoms, please contact your provider, go to the clinic. Or please be aware if you're living alone, if you are having difficulties already, if you already have a mental illness, please, be close to your mental health provider. None of that was included right from the get-go. So already they were not covered. And then because the system was already not great, as they present, we are not able to cover them all.
Yes, lovely, lovely. Now, Doc, we've been talking more looking at the problems, within the system, whether we're talking at general population level or we're talking at the workplaces or even the medical profession. Now, let's switch and look at what needs to be done. What is it that needs to be done to now get South Africa to turn around the situation so that we can look forward to better healthcare services for mental health users? Yes, change can't happen, overnight, but just to start to turn the ship towards the right direction in terms of, all the problems that we have highlighted. What ideas, do you have? If Minister of Health, Dr. Mkhize, had asked you to just give him about 4 or 5 things that if they can be done, they would make the biggest difference in terms of the quality of services to mental health users in the South African context.
If Dr. Mkhize asked me, there is one answer that, I'd say, no, I'll give you one as opposed to 4 or 5, which would be a lot of this stuff has already been gazetted. It's in the policies already from long ago. So all you have to do is enact them. That's it.
Yes.
So it's a one answer. But in reality, of course, we can't say that to Mr. Mkhize. So we have to say, Dr. Mkhize, maybe we should stratify areas, in terms of numbers of personnel.
Yes.
Dr. Mkhize, you have to do something about the numbers of personnel. Yeah, it's not an immediate solution, but it is a solution that the country will need going forward in terms of working on finding the money to train more personnel, okay, at all levels, not just psychiatrists and things, because I mean, you need to have personnel from primary healthcare, which is already something that was discussed. I don't know which policy it was, but it was long ago. You know, and they reinforced it. I know in 2018 it was reinforced that primary healthcare should be strengthened, and there should be integration at that level. You know, simple things. Well, I think they're simple, or they're simpler, like having healthcare workers, you know, who go out into the community to educate, to screen, to, you know, find the unwell or the sick or those who are going to be sick and referring them. That type of thing, right? But I mean, more investment at primary healthcare level.
Yes,
that is something that has to happen. And then, of course, look at all the laws that don't support good mental health. You know, for the 17% or whatever that is looked after by private care, it should actually then, if people are paying for private care, it should serve them fully. You know, and if it served them fully, then they would reduce this burden that goes to state. You know, that there are very few, or if at all, out of hospital benefits for those people paying for private care, and that is part of the PMV law. It's not fair. Oh, it's not just, you know, because then you still pay your private medical aid, but you still need other services that you're going to pay cash for, which is unreasonable. So that should be looked at. I come back to private care, to primary health care. The largest numbers of people have got anxiety and depression. Those are huge numbers. These people do not need tertiary, the majority don't need tertiary care. They don't need to see a specialist. They can be treated at primary health level. And it's a huge number, but it can be treated there. So if you could shift, or, you know, task shift and take all these people down to primary care so that the specialists are doing more complicated things. And then the other side of this would be the people with severe illnesses, like a severe schizophrenia. You know, they also have to have a lot of services in terms of, you know, having the right medication, the chronicity of the conditions that keep them unwell, and therefore their outpatient care and maintenance should be very, very good. You know, and there should be facilities to look after them. Another huge area that impacts on all areas of mental health and is a mental health problem itself is substance abuse. There are very few facilities for substance abuse, especially in the state. Very few. And these are not well subsidized. We need substance abuse in itself causes mental health issues in itself. And to those who already have mental health issues, it makes it worse. It makes the actual illness worse. It decreases compliance with any treatment regimen. And then thirdly, obviously, it causes physical illnesses, you know, problems with your heart. I mean, problems with your brain, problems with your liver, problems everywhere. So substance abuse needs special attention at, you know, serious investment. Education should become more integrated. You know, everybody now knows about COVID because it was out in the air everywhere, you know. But mental illness has been there for all our lives and our great parents' lives. But it's not there out there in the air. We don't hear about it. We don't see anything. And that is the type of effort that should be put in. Because once people know, they can act differently. If they don't know, they can't act differently. And of course, once they know, you have to make sure that the service is available for them. And in terms of increasing service points, with the necessary staff is vitally important. There are lots of service points in like the urban, well, there are more service points in the urban areas, but then the populations are higher as well. So they are still equally full. I told you about my Zola clinic experience. And then when you go out to the rural areas, the service points are so far between. You know, people either have to walk or take taxis or whatever to far away, and they're far from home. You know, it is best when people are accessible to a service, then they will use it better. But if it means that I have to leave at 5 o'clock in the morning and take 3 taxis, go and stand in a queue for 2 hours, and I still have to come back home and look after the children and cook and work and whatever, it makes it impossible. And for people who are working, that means a day of work, off work. It becomes economically not viable.
Yes.
These are things that I think Dr. Mzoledi must look at.
Yes.
And of course, we've seen that with the COVID pandemic that is going on. I have thought that if Wi-Fi was more accessible to more people,
yes,
and we didn't have to pay large amounts of money that we do, and especially for rural communities, we could be able to consult more readily on a telemedicine level.
Yes.
Because, I mean, now with the lockdown, it became clear that we should be consulting more on telemedicine. But when you try and contact the patient, then they have no data. They can't talk. You can't see them. You can't even hear them. And this would have been something, or is going to be something that obviously the world is moving that way. So it should happen that way. That a lot of people don't have to be traveling long distances and paying a lot of money when they could just actually sit at home and see their healthcare provider. And then, of course, there's also the other advantage that healthcare providers in rural places or faraway places can consult with specialists in town or wherever they are without having to send the patient in an ambulance, 5-hour drive to a center. It is not economically wise.
Yes.
I think these are some of the things. And then, of course, people must, unfortunately for all of us, is that people with mental health, with mental issues are the most marginalized, and they have no voices whatsoever. So they don't stand up, they don't fight, they don't shout. And if they did, with the stigma that is there, they would just mostly be booed and laughed at. But we forget that mental health is all our issues. It's not just about the patients, because the patients are also our fathers and brothers and cousins and whoever else. It's our issue. It is not just about families and communities. It is also an industry problem, because this is the workforce. And if the industry doesn't stand up as well to say, I want my workforce to be well and functional, then it's a problem. It is a government issue, because the economy is going down or is not being sustained because of the number of people. As you've said, 25% is a huge amount. 25% are not being economically viable. So the government is losing. It's losing on productivity, and it's losing even more on treatment, because if they're not picked up and treated there at primary health, they end up at tertiary health. It costs a hell of a lot of money. And then it costs a lot of money to the individual as well, economically, especially aggressive illnesses, because then they're at home, they're not earning anymore, and often they need somebody to look after them. You're looking at schizophrenia, you're looking at dementia. They need somebody to look after them. And substance abuse, of course. So the family is losing economically. The government is losing. Everybody loses. So mental health is all our issue, and we must all stand up.
Yes. Now, on the point you mentioned around leveraging technology, and countries like China and even the US, who are lucky to have more access to, a good broadband and connectivity, they've used technology successfully to support their people, even in rural areas. And in South Africa, it's a doable, because Telkom actually partnered with some of the universities to actually zero rate certain services for students so that they can be able to have remote learning. Now, if it is possible, to have that kind of an arrangement, I'm sure, something could be worked out such that when people are going to make use of psychiatrists and, psychologists, they could be able to have some zero-rated type of services that would then make sure that they access the services without them having to pay to buy data, Yeah. But in closing, Doc, was I'd asked you for 45 minutes. We only have got 5 minutes now to an hour. As the president-elect for SASOP, South African Society of Psychiatrists, you are a critical stakeholder in the area of mental health as an organization. Do you see any role that you guys could play as an organization to actually lobby government to actually change things for the better, especially now that we have seen how things are after COVID. So I'm almost saying, going into that position, you're going to be the president in not so long from now. I'm sure there must be some lobbying, responsibility for you as a head of that institution or organization. Do you see any role that you could play to get the government to move faster at implementing and doing things that they had committed to doing long time ago?
Yeah, you know what? We do work with government already. It's not like we're sitting in our own little box quietly. We do have interactions with government on an ongoing basis at different levels. And, we are ready to help and government in whichever way possible. But I mean, things like training of specialists. By specialists, I don't mean psychiatrists, I mean all members of the health team. That is a government function. I think, we can only ask and shout and scream and beg and grovel for more. So that we do, and then we also are always in a position to help out in terms of in training ourselves, in terms of community outreach, that actually sort of that looks at the immediate problem as it stands now, as opposed to what the plans should be. So we would like for government to actually acknowledge, maybe that is what it is, acknowledge the problem and actually go back and make things happen. Biggest factor that has to be looked at is primary care. If primary care can be strengthened, it can make a big difference. If numbers of clinics can be, or healthcare providing centers can be increased, it will make a huge difference. And of course, we need the numbers of personnel, big difference. And if we are working together, we can also advise in terms of what is the best way of doing whatever, whether it is remote teaching or remote treatment, which, getting healthcare workers, especially like lay counselors who can go out in the public, we can train them. They don't even have to be trained at any special government institutions. If they work, we could have a partnership and we say these will train and they can go out and be screening, be teaching, be educating. We could, and I mean, I suppose being in position of being specialists, we are also very skilled, I dare say, in terms of training. So it's not just the lay health workers, it could be schools, In many schools, in fact, if not all schools, you'll find that the teachers are having the double burden of being teachers and everything else. They are half nurses. The school nursing system or school health system is struggling, if at all alive. And we could help to train just a specific cohort of people that look after schools. Because if, again, we've said that if we identify mental at-risk populations and identify those who are having early symptoms or minor symptoms, if they are there, the school is a good place to pick up those people and treat them, or at least start to channel them into where they should be going to.
Yes. Just on the same point, Doc, of SASOP, we've been hearing about NHI that is likely to come in 2026. Are there any inputs that you guys are, giving or in your engagements with the government, so that when that NHI comes, we don't have a repeat of the current situation where mental health services are really the poor cousin to anything that is physical health?
Yeah, we have been engaged in a lot of different forums of saying, what we think should be the best in terms of that, but again, a lot of it, I can't repeat this enough times, a lot of it goes to primary care, in terms of identification, in terms of channeling, in terms of services, in terms of what services are needed. We have had engagements at that level on a number of occasions.
Yes, lovely. The last question, Doc, then we're done. We had a terrible situation here in Gauteng a few years ago, which was the Isidimeni tragedy. Do you think as a country, we have learned lessons from that, which was, I would say, a poor attempt at deinstitutionalizing, people with mental health illness, with the hope that they would be treated at a community-based type of intervention. Do you think we have learned from that as a country? And if not, what do you think, would need to be done with some of the recommendations that came, from, people like Judge Museneke around that kind of issue?
I'm sad to say that we haven't learned a whole lot because nothing has changed. Dramatically.
Yes.
There hasn't been any facilities as far as I'm aware, that would do, the deinstitutionalizing. And deinstitutionalizing was talked about more than, I'd say, 15 years ago or more. Yeah, more. We're already talking about it, but nothing actually ever happened. I'm sad to say that our country has got amazing policies that cover most things. It is the implementation that then just doesn't work. I don't know if it's a matter of political will or the managers that are there to do it or whatever else, but it doesn't. So yeah, we didn't learn much. Patients after the many hearings, then people were moved from wherever they were to other places, and they're still there. And I think to the fact that it was not done in the right manner and into the right people was the biggest issue, and we are not having sufficient discussions with government in terms of how can this be done and who is the right person to move out to deinstitutionalize. And I think, look, I can half understand that issue that we are saying that people should be treated or kept closer to home. So that means they would have to have institutions or step downs or whatever it would be called that are closer to all the homes, so to speak.
Yeah.
But still, if there were, let's say, 5 per province, it would make a big difference. But they don't. Nothing has happened in that way. They have been rehoused in different institutions in a very similar manner, and no, we haven't improved anything, unfortunately. And the services are, I dare say, they have now been allocated or specialists and other people to see them, but there are still a lot of them in those areas that have now been chosen. And I think one other thing that also has made it a little bit more difficult is that some of them have been left in hospitals. And hospital is not where patients should stay. They should come in, get treatment that they need, and move to an appropriate area. So it has actually increased the burden of the hospital now that they also house the chronically ill that are not acutely ill, plus the normal work they're doing all the time.
Yes.
Sadly, we haven't learned much, or we haven't done much about what we learned.
Yes. All right. Now, Doc, thank you very much for your time. I've gone beyond the time I'd asked you to join me. Apologies for that, but thank you very much for giving your time. You've been very busy this past week, appearing on a number of, media stations. So for me to even demand your time during the weekend, which is your family time, I'm contributing to you not resting, which is important for your patients, from tomorrow going forward. So thank you very much, Doc. I appreciate your time. And thank you to everybody who joined us for this discussion. We will continue to have discussions like these, not only during World Mental Health Day. I think issues of mental health are issues that should be discussed 365 days a year, because it is something that is that important. So thank you very much, Doc, and I hope to talk to you in the near future. Thank you.
Thank you very much, Dr. Nyati, and thank you for the work you're doing to sort of spread the gospel and let more people get to know, get to learn, get to understand better about mental health. We really appreciate it as well. Thank you.
Galebo, thanks.
Dad.
All right.